on optimizing RA outcomes in our country, state-of-art care versus financial constraints.
Thank you very much. It's such a pleasure to be invited as a special speaker at this conference. It's a wonderful, well-organized conference, and we're learning a lot. I am not going to talk about state-of-the-art, cutting-edge technology, but what I'm going to talk about today is the practicalities of treating patients in our setting. I think we have now matured to a stage where we can feel confident about our own abilities, and we draw lessons from our own experiences, as opposed to the time when we were totally new in this field so many years ago, and we had no local data, no local experience, and all we had was the Western literature and our experience of treating patients in the Western countries. But over time, we have learned a lot, and learned a lot of how to deal with these issues. And today, my aim is to try and impart some of my experiences to this audience who are the future torchbearers of rheumatology in this country. So, as you can see from the title of my talk, we need to optimize rheumatoid arthritis treatment because we have financial constraints. And the reason for choosing this is because in the West, with far greater resources, the talk is of treating to target. You set a target and treat the patient to get the best possible results. So this medical strategy, as you can see from the slide, that aims to reduce the signs and symptoms and get to either a state of remission or a low disease activity level of rheumatoid arthritis with the available treatment options. This has been espoused by several treatment trials in the West, and the largest of them was this trial from Netherlands called the DREAM Registry. I'm going to talk about this. And these recommendations have been incorporated in both the ACR and the EULAR guidelines, which serve as the beacon for treating this disease all over the world. So what was the DREAM protocol in the Netherlands trial? They said that you need to see the patient so frequently. At the first visit, and then after 8 weeks, 12 weeks, 20 weeks, 24 weeks, 36 weeks, 52 weeks, and every 3 months thereafter. And you initiate treatment with methotrexate, build it up to 25 milligrams or to whatever level it's tolerated, add sulfasalazine if necessary, or replace sulfasalazine with an anti-TNF agent, and aim for remission. And if you don't get remission, you get a low disease activity level. So this was the DREAM trial for the treat-to-target approach, the target being what I just told you. Then the other arm of the trial was the outcome of patients with usual care, without a target having been set, but just limited to what the physician felt should be done for the patient, given all their resources. So there was no strict adherence to when should the patient come. There was no setup or sequential therapy, and treatment was added as and when considered appropriate by the physician. So what were the results of this trial at 2 years? People who were treated to target, 65% of them had stayed in remission after 2 years, and they'd reached remission early. Whereas in the usual care, only 35% were still in remission. At 3 years, 60% were still in remission who were treated to target. And again, in the usual care, only 35%. Anti-TNF during the first 2 years, well, 22% had needed them in the treat to target cohort, and only 15% in the others. And you can see the cost difference. This is in euros in 2011. In 2 years' time, the treat to target patients had cost 4,800 euros to be dealt with, whereas the usual care patients were far cheaper to treat, 3,700 euros for that year. Then there was looking at the other trial, and this is also relevant to our setting because we deal with established disease more often than early disease. There was this trial of adalimumab called the OART trial, that even in established RA, treated with a specific biologic agent, patients will get into remission. And if you were to treat to target, you would change the biologic agent and get better results. So the conclusion through these trials in the West has been that if you set a target, and if you're not limited by financial resources, you're going to get good results. Absolutely right. So if we compare these two approaches, treat to target versus the so-called treat to budget approach, and the main focus and main objective, and we look at these things, then the main focus in the T2T group is patient's overall outlook, the patient's prognosis. Whereas in the treat to budget, you look at the patient's paying ability. The treat to target approach increases cost. The results are pretty good, but there is some argument for treating to the budget approach, even in the West. Now, with that background, come the ACR 2021 guidelines. Babar mentioned these guidelines in his talk, and I'll just take these two bits out of those guidelines, that when laying down the way you should be treating patients with RA, these recommendations are not prescriptive. They do not dictate that this is exactly how you're going to treat patients, and individual treatment decisions should be made through a shared care decision-making process based on patients' values, goals, and preferences. Herein lies the crux, that make it a shared care decision. And this becomes the guideline for physicians like us all over the world. NICE, the National Institute of Clinical Excellence in UK, each sort of health authority in UK seems to have developed their own protocol, but this is a kind of a general guideline that they follow if a patient is started on a disease-modifying drug, that you do these tests according to this kind of a schedule. You do full blood count and liver function tests every 2 to 4 weeks for 3 months, every 2 months for the next 6 months, and every 3 months thereafter. And if you change the DMARD, then you go back to the more frequent scheduling of tests. Again, keeping in mind that they don't want to take any chances if at all possible. They want to get the best possible results, and this kind of a protocol gives them the kind of results that the treat to target approach has been mentioned earlier. That does. Now, with that background, lessons, publications, guidelines coming out from the West, now let's look at our country, and let's look at how we sit in the world and where do we sit in the world. Our population is 221 million, and we are 2.8% of the world's population. Our median household income per annum is $4,000. In USA, it is $43,500. In UK, it is $32,000 per annum. So even compared to UK, they're 8 times richer than us. And our population demographics are different. 37% of our population lives in the cities, whereas 63%, two-thirds, still live in the villages. And it is the opposite, or more than opposite. I mean, 3/4 live in the cities in the West, and 25% live in the rural areas over there. We have a very different patient demographic, and this has connotations. Now, having looked at where we live, how we live, what we earn, what is this public healthcare system in Pakistan? I'm going to talk frankly about the system we have. There's no glossing over things, and I'm going to talk about how I see things as they are. The public healthcare system in Pakistan has got three components. There's the primary health, the secondary health, and the tertiary health. What is the primary healthcare? This is in the form of what are called basic health units, which are standalone facilities. You have a building somewhere with a staff appointed, which isn't there all the time, and this building is meant to serve that local population for its primary healthcare facilities. And it has no means of keeping a central record. It has no means of enforcing referral to higher centers. It is just there. Whatever they have is available for the local population. If they get any benefit from it, fine. If not, tough luck. And then the secondary healthcare is in the form of district or tehsil headquarter hospitals. Again, larger buildings, more doctors, but very few facilities. You have a patient with a head injury, go to some other place. We can't handle you. You have a patient requiring acute laparotomy at night. Sorry, we don't have a surgeon at night. We don't have ICU facilities. Go somewhere else. And the somewhere else, in the end, are the big cities, where the population that lives is 37% and 67% lives in the villages. And the tertiary care, in the form of large hospitals, usually associated with a medical college, are always short of budget and have only pockets of excellence. Yesterday, we heard from the professor of gynecology at Gangaram Hospital, where she said that we do not have facilities to do any autoimmune tests at all. And any tests that need to be done have to go to private labs. This is so true in most of the public hospitals in the country. This is a basic health unit. This is 1984 or 85. This is where I was posted. And you can see me, a young Abid Farooqi, standing in front of his new office in a village. And this village, mind you, Chahan, is where the founder of the College of Physicians and Surgeons is buried. The founder, General, sorry, I forget his name, it'll come back to me, but General Burki, Imran Khan's uncle, founded the College of Physicians and Surgeons in 1962. He's buried there, so it's not a totally out in the woods village, it's not too far from Rawalpindi. This was a building in 1984. No road then, no road now. This sign on the roadside points to that building. I visited that 20 years later. It was still the same. This was on one side of the village. On the other side was the village itself. And when I was posted there was no electricity in that basic health unit. The village had electricity, the health center did not. And the private healthcare system in Pakistan. General practitioners operating out of individual private clinics. No mandatory training requirements to be a general practitioner in Pakistan. You just get your MBBS degree, do your house job, get your Pakistan medical dental certificate, and you're there. Treat patients, charge fees. And these private standalone facilities are a mixture of doctors treated through medical colleges and hakims and homeopaths, and they are dotted all over the country. And the secondary healthcare service, specialist clinics, again operating out of individual clinics. No mandatory system of license renewal in this country. So once you're there for good. No matter how good or bad your knowledge is, it's entirely up to you. No checks. And tertiary healthcare system. We have in Lahore, everywhere in the country, private hospitals, small and large, highly variable standards of care, but one thing being common, they're all extremely expensive. I shudder to think what would happen to me and my family's budget if I were to be admitted in one of those and needed ICU care. All my savings would go in one admission. And I'm not all that poor. This is how expensive they are. So with this kind of a healthcare system, you can see the figures published in a paper from Pakistan that 31.5% of healthcare encounters are in the public sector and 68.5% are in the private sector. Public has very little faith in the public sector system, and the public sector system isn't there to cater for all. Out-of-pocket expenses, 81% are in the private care. And the Pakistan health budget is less than 5% of the total healthcare of the country. And I'll just put it in perspective. Out of interest, I'm talking of 1995, and things have not changed. I was working as a locum consultant in Southampton General Hospital, which is a big hospital in the UK, and on my desk came a paper about the annual health budget of that health authority, including that Southampton General Hospital. I had a look at those figures, and I realized that that particular health authority's health budget was more than the total health budget of my country. And this is still the case. And with this kind of a thing, what is the quality of healthcare in Pakistan? It is fragmented. No accountability. Every one of us is there, independent. The only person who audits us is a taxman once in a while. Nobody else. And there are no set standards for note-keeping. There is no centralized note-keeping anywhere facilities. And all the patient's records are carried by the patient in their hands in the form of papers, which are either prescriptions or short notes or tests. And it is rare to see OPD notes which give any indication of how and why the treating physician has prescribed what he has. So the patient with a chronic disease is going from place to place, searching for a better treatment option, and there is no good stream or line of reasoning available for the next physician to see what has been going on. Now let's look at the RA demographics in Pakistan. A study done by Dr. Gibson and myself, and then Dr. Gibson also did a similar study with Dr. Kamran in Karachi. This is back in the mid-90s. 0.5 to 1% of our adult population has RA. That translates into 500,000 to 1 million people, adults in the country with RA. Now, 2/3 of these are living in the villages. And majority of their healthcare expenses are out of pocket. And each visit to a rheumatologist would entail substantial costs. And I'm going to talk about these costs. Now look at this. This is just an idea of how much it costs. You travel from the village to the clinic, the average cost in rupees, because no patient travels alone. The average cost ranges from 6,000 to 10,000 rupees. Doctor's consultation fees per visit ranges from 2,500 to 5,000 per visit. Investigations at each visit, 2,000 to 4,000 rupees. Medicines per month with conventional DMARDs, 3,000 to 5,000 per month. With targeted synthetic DMARDs, 14,000 to 35,000 per month. With biologic DMARDs, 20,000 to 50,000 per month. Wow, and all this burden on whom? Monthly household income in the rural areas is 20,000 to 60,000 rupees. In the cities, somewhat better, from 20,000 to 100,000 rupees. That's the average. I mean, of course, they're very rich people too, but this is the kind of average patient that comes. The rich people are very few in Pakistan. So this is the kind of pharmacoeconomics. Now, this is the village in Pakistan. I ask you, is it practical to treat to target this population with rheumatoid? For the majority, the answer is no. Too many mouths to be fed at home, too few resources, and if you're going to make it mandatory for all those conditions to be followed for treat to target, you are getting nowhere. So I'm going to tell you the way I see it, and this is the distillation of my 32 years experience as a frontline rheumatologist in Pakistan. And how do I see the requirements of being a rheumatologist in Pakistan? So can I just ask, how much time do I have left? Okay, I'm okay. 5 minutes. Oh, I need to hurry this up, but this is important. A rheumatologist needs to be equipped with the latest knowledge and best clinical skills in this field. But he has to be cognizant of the resource limitations of the patient. He has to understand the home culture of the patient and treat accordingly, and to aim for the best possible outcome without making the treatment seem impractical. This is the requirement of a rheumatologist in Pakistan. The typical RA patient that we see is illiterate or semi-literate, females more than males, accompanied by a relative who is himself semi-literate. They have limited financial resources. They cannot make frequent clinic visits. They have established disease with a record of patchy treatment, and they have come to see you now, the big doctor. You're going to cure us, aren't you? And one visit to you, one prescription from you, and this disease will go away. That's the kind of hope they come with. And the rheumatoid, now that we learn, is different. I published a paper again in the mid-90s telling out, and this was published in the then British Journal of Rheumatology, of the clinical nature of rheumatoid in Pakistan. And I mentioned, and it holds true today, oh, thank you, I have 10 minutes, excellent, that rheumatoid disease in Pakistan is a disease of the joints more than a systemic disease. In the Western literature, you will find that they will say that rheumatoid disease is a misnomer. It should be, rheumatoid arthritis is a misnomer. It should be called rheumatoid disease, and it has 25% of patients have systemic features. Well, in Pakistan, they don't. Only about 2.5 to 3% of rheumatoid patients have systemic disease. It is mainly a disease of the joints in Pakistan. Erosive disease is very infrequent. If I may correct Dr. Barber's slide, the slide he showed that the first year, very important, erosions will set in early. Well, they don't. You will see erosive disease in Pakistan, but very rarely. Now, whichever one of you is seeing patients in Pakistan, have a look at those x-rays each time you see the patient and see how many have erosive disease. They may have deformities. Erosions are so uncommon. My training in UK was to get the x-rays of the hands and feet, even if the feet were perfectly fine. Get the x-rays done because you'll see erosions there. I don't see erosions in the hands either. Well, I do, but very infrequent. Not even half as many as you would see in UK, for example. But deformities are frequent, and disability is frequent. The level of disability, and mainly due to knee damage, we are somewhere near the bottom of the heap in the world, because whatever the disease, whatever it's doing, is not being treated properly. So the disabilities just pile up. So if you're going to treat these patients in your setting, what is the requirement? You have to know the socioeconomic status of the patient. You have to establish the stage of the disease. You have to know the comorbids. You have to counsel them regarding long-term supervised treatment, joint protection advice, because our culture is to do so many things sitting on the floor, and choosing a proper DMARD therapy, choosing monitoring methods and follow-up, and you've got to involve the family members in this decision, because this illiterate person or semi-literate is dependent on someone else for the treatment most of the time. So my suggestions, now you're sitting in the clinic, you're seeing these patients, the first thing to do is establish a rapport with the patient. You need to follow them up. So you need to have some confidence. They need to have some confidence in you to be able to come back to you. So even if you don't speak their language, like I don't, most of my patients are Pathans and I don't know how to speak Pashto, but I still speak to them in some way or another so that they get the impression that this is a friendly person at least. And then you go on and then you make notes. The notes which are going to be passed on to you don't know how many other doctors, but what you write is going to be read by others. So it is important to write so that they know what you've been thinking. And I usually follow this regimen of SOAP, subjective, objective, assessment, plan, and pattern. I try and do this in my notes. And I try and ensure that a written copy of these is available to the patient, because there's no way else that the next physician is going to have access to what you've taught. Patient education is important. If it's early RA, you tell them that they'll do well if they can be supervised and they come frequently for follow-ups. If complications have set in, you explain the limitations of medical management because they're expecting a cure. And if the female is of fertile age, then you've got to guide them about pregnancies, because not having children in this society is tantamount to the marriage being on the rocks. So you've got to guide them about it. You have to manage comorbidities. You are a physician first, so you manage comorbidities. The only one comorbidity that I refuse to manage is diabetes, because that needs frequent contact with the physician, and I try and usually delegate this to the local physician because I cannot be responsible for that. But blood pressure treatment, other treatments, you can manage and guide. The prescription. It is important. Remember again, now we're treating patients. We want to get the best results. The writing on the prescription needs to be legible. I come across prescriptions which I can't make head or tail of. So I don't know who can. So this is important. You write these things down because there's no one else to do it. Using generic names is not practical, so you use trade names. And always explain to the patient that if the name that you have written is not available in their local medical store, they must ask for an alternative brand. They do not have to be bound by the name that I have written. Give them the choice, make it flexible, make it easier. And always mention the tests you need for the next time. And follow-up visits must be arranged, not just left at the patient's discretion. You've got to give them the guideline. Whether they can come back or not at that time is a separate matter. But it mustn't be understood that you have just left it to their discretion. This is my grouse against the Pakistan healthcare system, that even in the largest teaching hospital or whatever, it's an on-demand medicine being practiced. When the patient feels it's time to see the doctor, then they are welcome to come to the hospital. Otherwise, go away. And that's not true. You've got to tell them how and when to come. They may not be able to follow this, but they should come. Now I'm going to talk about the drugs that we have. The non-steroidal anti-inflammatory drugs use only those with proven efficacy. Avoid piroxicam. I bring this point because some people are still again prescribing piroxicam. Piroxicam for me is a big no-no. 18 times the risk of GI bleeding as compared to somebody, say, on ibuprofen. Why should I take this risk when diclofenac only gives me a 5 times greater risk? Please do not use piroxicam. Try and reduce the use of NSAIDs whenever possible. Always prescribe a gastroprotective drug when you give them an NSAID, and avoid COX-2 inhibitors in hypertensive practice. and those with ischemic heart disease use naproxen. These are standard things. And steroids. I need to emphasize this point, unfortunately. Use prednisolone, not betamethasone or dexamethasone, because those are longer-acting drugs. It takes longer for the pituitary, the hypothalamic axis to recover. So try and use prednisolone and use the lowest possible dose and try and taper them off whenever possible. A large number will still continue to need low-dose steroids, but you have to accept this fact. Even in the European cohorts, 25% of patients are on long-term steroids. DMARDs, heaviest reliance on conventional DMARDs. Common side effects should be mentioned. Procedure for communicating drug-related problems should be made clear. How to contact the prescriber if you have problems. Use targeted synthetic DMARDs or biological DMARDs whenever required and affordable if 2 or more DMARDs have failed. The non-conventional DMARDs. We now have tofacitinib available. It is the cheapest of all the other non-conventional DMARDs. So it has been available since the last 1 year. All of us have started using it, reasonably good results, but avoid using these in history with ischemic heart disease and a history of clots. Rituximab is the cheapest biologic DMARD and now has biosimilars also. Luckily, COVID hasn't been too much of a problem here, but then that is something that's been highlighted. So in this COVID era, be somewhat careful with rituximab. It is still the cheapest biologic DMARD available. Tocilizumab available, but more expensive than rituximab. Etanercept and biosimilars also now available, but most expensive of the lot. So which non-conventional? Do not try and follow nice guidelines or this guideline or that guideline. See your own local environment. So if conventional DMARDs have failed, use the cheapest option unless contraindicated for a medical reason. Impractical to follow international guidelines because TNFs, we don't start off with TNFs. Those are more expensive. Use them only when there is no other option. And rituximab in our country has the added advantage of not causing increased susceptibility to tuberculosis, which is otherwise such a big problem. Monitoring tests, do not insist on a bookish schedule. Check tests initially, then at every follow-up visit. Choose ALT as the liver function of choice, not the whole gamut of liver function tests. And allow patients to get tests done from the local laboratory so that results are available when you meet them. Remember, they're coming from a village. They do not have time to get fresh tests done, wait for the result, and then go home. They need to go home that day. So unless the results from the local lab are terrible, just accept them. Thank you. Surgery for RA in Pakistan. Joint replacement is possible and feasible for knees and hips only. Cost is high and hence out of reach for most patients. Finger and toe corrections not advisable due to lack of frequent hands-on experience by the surgeons because they're expensive. I remember doing hand clinics with plastic surgeons in the UK, excellent results, but then the patients were there all the time, the surgeon was there all the time, and the cost was not borne by the patient, it was borne by the National Health Service. So, wow, terrific hands, beautiful toes. In Pakistan, you send a patient to the hand surgeon, they do surgery which looks good, and then it goes all right. And there's no recourse, and it's been expensive. And the surgeons do not have experience because very, very few patients are getting them done. So, doctor, my hands are so poor, I don't like them, can I get them corrected? Yes, you can, but I would not advise you. Accept them as they are, as long as they're functioning. If you can't function, then okay. We would try whatever is available, but do not get surgery done just because they're deformed. Ankle and wrist arthrodesis are needed so many times, but the patients don't accept the need for arthrodesis. Tough luck, I don't know, but that's our culture. So in this setting, with this kind of a facility, are we seeking remission or low disease state activity? Yes, but only for those who can easily afford the cost. And this percentage is very small in Pakistan. So know the ideal, but practice what you need to. The non-compliant patient, I'm coming back to the end of my talk now, only 2-3 slides left. So the patient hasn't come back for follow-up at the right time. Why? Well, I felt better, doctor, hence I didn't come. I was short of money, doctor, couldn't afford to travel. And there was no one to bring me to your clinic, doctor. I'm the female in the house. There was no male member. I couldn't come. Oh, sorry, somebody had died at that time. I couldn't. And so many more excuses. So what do? Do you get angry? No, I've learned not to. I used to. No longer. It doesn't work. So nothing more than a gentle reprimand, please. The mere fact that he or she is back to see you is a statement of trust in you. So respect that, appreciate that. Act like a parent figure and get on with the best professional advice you can give. And the one who didn't come back at all, well, there will be many who will not return to you. Seeking a second or third opinion is always the prerogative of the patient. But if you've done your best, the chances are they've gone to another rheumatologist. Isn't that right? You have seen patients that I have seen patients that you've seen, and therein lies the success story of PSR. Were international standards met? No. What was achieved? We achieved an improvement in the quality of life of a patient who otherwise was destined for a miserable life. We raised awareness across all strata of society about rheumatology being a separate, valuable specialty. We instilled enough trust in the patients that subsequent opinions were sought from qualified persons most of the time. And the end result is that we now have a huge amount of indigenously acquired expertise for our country, translating into reduction of disease burden in our society. And this holding of the Silver Jubilee meeting is with the satisfaction that our results have not been in vain. Thank you so much.
Thank you so much, Dr. Abid Farooqi, for an excellent talk. Before we proceed with our Q&A session, I'd like to announce that our Honorable Chair, Professor Dr. Salimuzzaman Atmi, have joined us, who is an Associate Professor, Head of Pulmonology Department at Shalimar Medical and Dental College, Lahore. Thank you, Dr. Salim, for joining us. The floor is now open for questions. You may hand your questions written on question cards to a member of the hall committee.
Thank you so much. The first question is addressed to Dr. Babar Salim from Dr. Bina Hamid. For patients with negative serology and ultrasound, would you do MRI with contrast if suspicion of inflammatory arthritis is high, or will you wait and see?
Hello. I think no. The reason being is that in Pakistan, unfortunately, we do not have the expertise of picking synovitis on an MRI. I'll have to work. That would be a burden on me to sit with the radiologist and checking on if there are any. So practically, we are not doing it. So we just start the treatment if we have a strong suspicion on the clinical grounds. We start the treatment and we observe and we follow up the patients. And we, in subsequent visits, most of the patients, we do find some kind of synovitis. And on the subsequent visits, I find that there's no synovitis. So I stop all the medicines. And again, I observe for a couple of weeks.
Thank you, Baba. You have another question. If a patient presents with typical features of RA, but serology is negative and duration of symptoms is less than 6 weeks, what will be your differentials?
My first differential would be, it could be viral, but you need to know that the viral, I've been taught by Professor Abid Farooqi, and he has shown us so many things that in viral, normally the pain increases, like it is initially it's very too much, and with the passage of time over the period of weeks, it declines. So in the typical history, the patient would be saying that I initially in the in the initial days, I had a lot of pain and swelling and stiffness, but over a period of without any treatment, the pain started to decline. So that gives me a clue, but it's not gold standard, but just a clue that probably this could be viral. And there are many other differentials as well, including infective endocarditis, so many other things like psoriatic arthritis, but we need to keep viral arthritis in a very short time as a differential as well.
Thank you so much. Now I'll ask Dr. Kamran Chima to please answer a question from Dr. Tariq Iqbal, a consultant rheumatologist. In scleroderma-associated ILD or RA-associated ILD, how long will you give MMF?
How long will you give?
You give mycophenolate.
Okay, so in scleroderma lung study, they gave cyclophosphamide for 12 months, and then they stopped it, and eventually at 24 months, the FVC had started declining again. And based on that, I think you need to continue giving the medicine. It will become simpler once generics of nintedanib become available, because I think that will cover both UIP and NSIP, and it's not a very toxic drug, but that has not happened yet. It's a very expensive drug at this time. So I think all the trials are showing that we don't make the disease go away. So you prevent the rate of decline of lung function. And what I tend to do is I go down to the lowest dose and just watch them and see what's happening after a year or two, because drugs are expensive. They're going to stop taking it anyways after a while. And Dr. Abid Farooqi has highlighted the problems of taking care of people here, and I wish I had listened to him when I first came to Pakistan, but he was also young, as you saw in that picture. So a lot of things that he has said are actually lessons that I've learned, but I've not grabbed them, and with your permission, I'll borrow some of your slides to share with my juniors. And on one of the things, which is aside from the question, but I have an opportunity, I want to congratulate Professor Nigat Mir and Professor Abid Farooqi for having created a tradition amongst rheumatologists which is different from the practice of Pakistan. I see prescriptions from all rheumatologists in Pakistan, or at least in Punjab. And your specialty, I see people that you've trained, they are putting thought into their prescription, they are documenting everything, they are giving typed prescriptions to their patients. You can actually see a prescription from a rheumatologist, any rheumatologist, and know what they're thinking, which is not true of any other specialty. I've seen that. I've tried in my specialty, but very few people follow the lead, and there's one who writes very nice flowery notes, but sometimes they don't make sense. But I think this is particularly true of your specialty, that, one of the advantages being this is a second fellowship, and that makes a big difference, whereas in Pakistan, everything is a shortcut. So you can become a pulmonologist without doing your fellowship in internal medicine. And those people, unless they're trained with someone who emphasizes documentation, miss out on those things. And Professor Salim has told me that in Iraq, it is forbidden to give a handwritten prescription. Every prescription in Iraq has to be a computer-generated, printed prescription. And look at us in Pakistan. We are not there, and I don't think we are going to get there. So
you have a few more questions.
Sure.
At what point shall we consider treatment in progressive UIP associated with rheumatoid arthritis? And what options do we have? This is from Dr. Qasim, a rheumatologist.
Dr. Qasim, very good question. Firstly, the question is very important. You've understood the point that not everyone with RA-related ILD needs to be treated. There will be people who have ILD and whose disease is not progressing, and they don't need to be treated. Who needs treatment? Usually, we either want the, that slide was towards the end, and I was short on time. But if an FVC of less than 70% or a DLCO less than 70%, or a rate of decline of FVC of more than 10%, or in a person whose rate of decline of FVC is between 5 and 10%, but DLCO is also decreasing. Now, there are only, to my knowledge, 2 centers in Lahore that do DLCOs. One is Shaukat Khanam, and the other one is Services Hospital. And in Services Hospital, the test is being done for free. So, if any of you want to do some studies, I can put you in touch with the team there. Very nice team of doctors. I have retired, so I don't want to take credit for that, but I helped set it up. So we have diffusion capacity, we have lung volumes, body plethysmography, and for those who are interested, integrated cardiopulmonary exercise testing for people who may be having breathlessness and you don't know if it's vascular, if it's muscular, if it's interstitial lung disease. So as a corollary to the question, what would I use to treat those patients? We know that in UIP patients, like IPF, steroids and azathioprine are toxic and increase mortality. But we have been using these agents in our rheumatoid patients, and there are benefits to those agents for their arthritis, and they're sort of accepted if you think that the patient needs steroids or immunosuppression for their rheumatological disorder, and I would not stop you from using them, but if you didn't need to use them from the rheumatological point of view, I don't go and advocate using immunosuppressants in these patients. Pirfenidone is available in Pakistan. It's a generic, and everybody, Dr. Saira wanted me to talk about when to use pirfenidone. And I searched and searched and searched, and we don't have the data of using pirfenidone in autoimmune diseases or connective tissue diseases. The drug has a lot of side effects. The effective dose is very high. So it's not 1 tablet 3 times a day, it's at least 3 or 4 tablets 3 times a day. So at that dose, everyone has side effects, everyone has loss of appetite, they all start losing weight, and they feel miserable. And they also, some of them, it causes photosensitivity and it causes rashes, so that is where they overlap. You get more confused. I have not seen anyone of my UIP patients on pirfenidone coming back happy. But in UIP, you tell them that this is a progressive disease. If you don't use it now, your lungs will get worse, and you need to keep using them. Even then, they are always looking for excuses to stop using it. They'll say that the drug that you prescribed has run out of the market, and so I stopped using it. And they almost always reduce to a subtherapeutic dose, which may or may not work. So I'm hoping eventually that generics of nintedanib will be made by our neighbor and become available here, because that seems to work in these diseases. But currently it is, I have a handful of patients on nintedanib, only those who can import it from Germany or USA. Even pirfenidone is very expensive abroad, but because it's being made in India and it's being like trans-shipped from India to Dubai to Pakistan, it would be cheaper to just bring it across the border, but that is a different issue altogether.
Is that working? Is this working? This is working. A question for Dr. Farooqi, or a comment. Can I point out that the UK is not a centre of affluence or medical excellence, and some of the things you've been saying are totally appropriate to how we manage our patients in the UK, because they don't like travelling, they don't like taking their drugs, and they don't like doing their blood tests. A solution we're working towards is, should we use more electronic communications with our patients? to talk to them? Because after you've seen them once, you don't necessarily have to see them for another 6 or 12 months. And should we abandon doing blood tests?
Yes, thank you. You know, Englishmen are always very modest about whatever they've achieved. They have achieved such a lot. I mean, he says that patients don't like traveling. You just go to the UK and see. You find a hospital as big as the Mayo or the Gangaram every 15 miles. Every district hospital is equipped with better facilities than the best teaching hospital we have here. So, you know, he's being modest about it. And yes, I mean, there is a problem in the UK. The NHS is very expensive at the moment for anybody to afford. But yes, you can think about electronic records because you have electricity at the home of the patient, and the patient has a computer and an internet. You know, that's not what we have. Yes, if you do that way and if you publish such guidelines, it'll make it somewhat easier for people like us to apply them here as well. But till such time, all we have is our own experience. Blood tests. You know, this is so important. I'm glad he brought this up. The guidelines say you've got to do these so frequently. From the moment I started treating my patients with DMARDs, I realized they will not be able to follow this schedule. So I had to take a chance. I was playing God. Just take this drug, just go home, and come back 2 months later or 3 months later with the new test, and just keep my fingers crossed, hope for the best. And you know what? 32 years, only one patient of mine died because of methotrexate toxicity. I have not come across any fatalities when these patients are not done. This chap comes back 1 year later, and this woman comes back 2 years later. I have been following your prescription, doctor, leflunomide or methotrexate or whatever, and here are my blood tests. Absolutely normal. How were you in this time? I was okay. So totally agree with you. It's time. I hope people in the West revise that, but they play a more defensive game over there because they're afraid of litigation. Luckily, not such a big problem for us over here. We're getting away with it. My anecdotal experience is that we are doing okay. So if you were to learn this lesson from us, you might be able to relax a bit over there too. Thank you.
I'm just going to take 2 minutes, one quick comment. That is for Abid and Nikhat and Javed and Wajahat and Kamran, who's not here, Dr. Azra. I think all of us as a rheumatology fraternity owe a lot to these people who actually paved the way for us to be where we are today. So a big hand for them, please. Secondly, I think it's I'm now a grandmother too, so I'm a dadi. And I consider myself a second-tier parent to many of you who are sitting here. The first tier, also many of them are younger than me, except for Abid. But it's so good to see the trainers with the trainees, now trainers. And I think we've got like second, third generation sitting here. And again, kudos to these people who actually did the hard work, and then we were happy to join them and put in our hard work as well. So, and that was a comment. I must appreciate Saira and Bilal and the whole team for a fantastic conference. Thank all the speakers who've flown in from abroad. So just quick comments going backwards. Abid, completely fabulous, I think, presentation. We all know we have to deal with this, so I think the important thing is not to feel that we are any lesser for not being able to do a treat to target the way it is given in the Western literature. We are trying to treat to our targets that are achievable, which are doable for us and our patients. And I think considering the clinical load, we should give a little bit of, I don't think we do that badly. I think if you had this kind of a clinical load and constraints that we work with, I don't know how people would function in the UK and the US. So you try to be as humane and ethical as possible. And I think many of us are trying to do that. So that's one thing. Kamran, fantastic presentation. My question to you is simply that many times we find that pulmonologists do not want to cut in a situation where it is predominantly inflammatory disease like NSIP, even if they have been treated with, say, mycophenolate or on maintenance, or they've been rituximab, and you find that clinically their inflammation is getting better in the lungs. Steroids are still, I don't know, a lot of pulmonologists will tell us, no, we don't want to go below 10 milligram a day. And many of us as rheumatologists would like to cut that back a little. So just your comment on that. And thank you, John and Babar, for great presentations. Thank you.
I'll also touch upon one question which was about PCP prophylaxis with Septran, but honestly, I've seen very little PCP in Pakistan. As Dr. Farooqi says, he sees very little erosive changes, although you read about it in inflammatory disease. I have seen very little PCP because PCP occurs when the CD counts are really low. Much before that, the patient gets tuberculosis. So I've actually seen pulmonologists treating tuberculosis as sarcoidosis after biopsies and giving steroids patients, and patients coming by to me when on immunosuppressants with CNS disease. So I think coming back to your question, the lowest steroid dose, most of the time the steroid dose is dictated by the joint inflammation. It's for control of the joint symptoms and not for the lung disease. So the lowest dose. But the problem becomes in patients who have progressive disease, where you actually need to step up therapy. If a patient is not getting better, you start thinking about biologics. And Salim asked me what would I like to listen from a rheumatologist. And I said if I had to call a rheumatologist to give a talk, and I had to make sure that there was an audience interested to listen to that talk, and there was a pharma interested to sponsor that talk, then it would have to be about biologics. So if your patient is not getting better, think of biologics. If your patient is on biologics and not getting better, please think of stopping them because you may be causing more infections. And that's where we can come in and help you. So the lowest dose, but if a patient has progressive disease, it's very difficult. Your patients with inflammatory myopathies, myositis, they tend to have a more aggressive disease. They need pulses of steroids, pulses of cyclophosphamide, early rituximab, IV IgG, or plasmapheresis. These are the kind of patients I see. I used to see a lot in the ICU, but now they have already, you guys are taking such good care of them that they are picked up early, at least in the heart. And I am seeing much fewer patients coming into the ICU with diffuse alveolar damage. But we still see patients with vasculitis and alveolar hemorrhages coming in. Thank you. There are a couple of other questions that I can answer in person. They don't have the time.
Thank you. Thank you so much.
I'm afraid that's all the time we have for today's Q&A session. Feel free to ask any questions in the lunch break, And I'd now like to ask our chairs, Dr. Salimuzzaman Admi and Dr. Naeem Afzal, to give their brief remarks on the session, please.
Assalamu alaikum. First of all, I apologize for being late for this session because of some unavoidable reasons and problems in the hospital. I was unlucky to miss the earlier talks by Dr. Axford and Professor Kamran Chima, but I was lucky to hear the talk by Dr. Abid Farooqi, and it was really an eye-opener. We in Pakistan face the similar problems. We have guidelines, as he has correctly mentioned, but it's very difficult to stick to the guidelines because of
the lack of resources, and also because of the mindset of the patient, their financial capabilities, and many other factors. My real comment is that I'm so happy to be here in this conference of rheumatologists, because in Pakistan, until very recently, the rheumatology role was being played and is still being played by the orthopedic surgeons. Anybody has a joint problem, anybody has a pain, they go to the orthopedic people because they are more readily available. There are more orthopedic people available in our society rather than the rheumatologists. So it's great to see the rheumatology coming up, and as we all know that physician is a physician and surgeon is a surgeon. Surgeon will always think about surgery, but the physician will think about getting ways of avoiding surgery. So it's great to be here and to see so many people talking about specifically the pulmonological aspects of rheumatology. I'm a pulmonologist myself, and I'm very lucky to have Dr. Saira in our hospital, in Shalimar Hospital, as a rheumatologist. And she knows it that the moment somebody comes with a rheumatological problem and they have a shortness of breath, we get together as a team and we find out what is going on, and our efforts are coordinated for the betterment of the patient. So it's very good to be here, and I congratulate the organizers for this wonderful event, and I hope there would be more cooperation between our two societies, the Chest Society and the Rheumatological Society. Thank you very much.
Assalamu alaikum. Thank you very much for inviting me. I am an internist by training, and it's very good to see Pakistan Society of Rheumatology growing up, and beautiful bunch of rheumatologists serving the whole country, across the whole country. I've unfortunately missed the first talks, but the talk for Dr. Abid Farooqi was very eye-opening. And sir, you are very right that we have certain many restraints in our setup, but I think that some liberty of law and some cooperation by the patients, that is our strength also. And we should now, I think this is the right time that we should get two things now. That Dr. Axa said that one thing that we should use telemedicine. I understand that this computer and internet, that is not very frequent in use, but mobile is so commonly used in Pakistan, and everybody, someone at home is using mobile anywhere, in any part of the country. And 100 rupees mobile load can be used for a web hosting meeting or when anything by the patient, and that prescription can be emailed or like printed or given to that patient on whatever platform is. That can be a better way to treat, to target. I understand this is, we have certain limitations that we cannot go for the remission. We're going to target the complete remission as the UK and US, they aim for. But we can be closer to that. And lastly, that I suggest that PSR should now announce and launch a registry of rheumatology across the whole country with the help of all these bunch of beautiful and qualified and dignified rheumatologists across the country, that we should come up with our own data and our own guidelines. And not only we should learn from other colleagues, but we should also learn from the patients that what home remedies and what home physical therapies they find useful for that. And we can take those home remedies and home physical therapies to the labs for inflammatory markers, that what are they finding good and useful for them, and we should incorporate in our own guidelines. And lastly, from the internist point of view, I think that pathways of treatment that should be more communicated to the internist as well as general physician, that this is the point where, at which this case definitely needs to be referred, and this case must not be lingered on. And this case might be treated by the physician or might be sent back to the GP for the follow-up and later on consulted by the rheumatologist if necessary. So these communications and development of own guidelines, I think this is the right time and nice time to step forward for the betterment of our own country. Thank you so much.
Thank you so much. Now I would request our worthy chairs to please come for the shield distribution to the speakers. Sir, इधर आ जाएं. Professor नहीं, नीचे. Now I would request Dr. Babar Salim to take his shield from the chairs. Professor Naeem, please join us for the distribution of the shields. First shield for Dr. Babar Salim. Then I would request Professor Kamran Chima. Next for Professor John Axford. And the last speaker, shield for Professor Dr. Abid Farooqi. Now I would request for Professor Dr. Abid Farooqi. Now I would request Professor Wajahat Aziz, Professor Bushra Jameel, and Professor Nigat Mir and Dr. Javed Malik to present the shield to our respected chairs. Thank you. So, the first shield. I would request Professor Wajahat, Professor Bushra, Professor Nigat Mir and Dr. Javed Malik to give the shields to Professor Dr. Salimuz Zaman. Next, our worthy chair, Professor Dr. Naeem Afzal. And then Dr. Uzma Rashid. Thank you so much, everyone. Now we'll start with our next session of the conference, for which I'll hand over the mic to the stage committee.